discuss intrauterine transfusion because there is one procedure. So I want all of you to be oriented with it. What is intrauterine transfusion? So this is one of the success story of the fetal medicine, intrauterine transfusion, because there are a lot of fetal therapy, but this is one of the fetal therapy which immediately you will see changes happening in the fetus, and we can rescue those cases of RH aluminization cases. Okay. Now, this is one of the successful, most successful in vitro fetal therapeutic procedures in today's era, and some key points I want to highlight here is aim of this process is that those fetus which has developed anemia due to any cause, anemia may be because of RH isoimmunization, it may be because of some non-RH related disorders also, like parvovirus infection or some hemolytic disorders. So any kind of anemia. And how do we diagnose anemia in utero, that also I will discuss later on. So this is basically the aim of the procedure. Aim of intrauterine transfusion in fetus is to prevent or treat fetal heart failure, which manifests in fetal life in form of high drops, and allow the pregnancy to continue to a stage where a viable baby may be delivered. Okay. Now, I have highlighted here, it is used in treatment of choice in management of fetal anemia resulting from both RHD and non-RHD aluminization, like parvo, chronic fetomaternal hemorrhage, homozygous alpha thalassemia. Okay, so not only we are dealing with RHD, but non-RHD aluminization also, like these three conditions.
Now, in case of chronic fetomaternal hemorrhage, it's usually ABO mismatch.
ABO mismatch. Okay, so those are rare cases. Common is RHD aluminization, but non-RHD also we have to keep in mind whenever we see. Because when we ask mother she is RH positive, then we cannot be complacent. Still, baby may have anemia due to some atypical antibodies or non-RHD related causes, as I have highlighted here. Now, on ultrasound, when she comes with some history, if it RH negative with baby having hydrophic features and all, then it becomes easier. But otherwise also in all RHD negative mother or RH negative mother, irrespective of her status of anti-D immunization, we have to do MCA Doppler, because this is something which is absolutely non-invasive and it gives an idea that baby is anemic or non-anemic. So any RH negative mother, irrespective of her anti-D status, we have to do MCA Doppler in every visit from 18 weeks onwards. Is that clear? Now, how do we diagnose or have a hint that baby is developing anemia? We did MCA Doppler, and there is a criteria how do we do MCA Doppler. But important thing is to look at the MCA. I mean PSV, peak systolic velocity of MCA. If this peak systolic velocity is double the gestational age, it is equivalent to 1.5 multiple of median. Like at 20 weeks, if it is 42, 40, 41, 42, it is double the gestational age. That means it is more than 1.5 mom. Okay. And anemia is defined in fetus as in terms of Dopplers, that MCA PSV mom more than 1.5 multiple of medians is suggestive of fetal anemia. But there is a nomograms, there are online calculators, we can go and check. But the thumb rule, bedside thumb rule when you are scanning, is just to look at the gestational age and see what is the peak systolic velocity. But for that, your Doppler optimization should be very good and angle of insonation should be as close to 0 degree, because your peak systolic velocity and Doppler will change with the angle of insonation. I will show you that in my growth restriction. I have taken the video loops. I will show you that. But we have to be very particular about the Doppler ratings and do 2-3 times repeat so that we are not in the false positive side. Sometimes it happens. So now, suppose we have detected a case where it is affected and now we need to treat it. Now we need to treat it. If we don't treat it, it will die out of heart failure. Because what does anemia cause? Hemodynamic overload. There will be less viscosity and there will be hyperdynamic circulation. And this hyperdynamic circulation will lead to too much of preload on the heart, fetal heart, and eventually a state where it starts decompensating and starts failing. And failing heart in fetal life will manifest in the form of high drops. High drops. Like the case which we have today has, just I saw the paper, is having ascites and placentomegaly. So these are all signs of high drops, that baby is undergoing heart failure, decompensation. Now choice is to leave it or to take it. Take it in the sense, put in a needle and try to rescue the baby, that is the last attempt. Or if you leave it, it will die. There will be demise. Okay. And one more take home, don't believe that 31, 32 weeks anemic baby, I will deliver it out. Because that is the worst possible decision you will take as an obstetrician. Anemic premature baby is the worst combination. You never want to deliver an anemic premature baby. Even if it is 36 weeks, do a top-up transfusion and then deliver the baby. It will be much easier to manage in NICU, those cases. Because people say that if I talk to doctor, I call him on phone and say, oh, baby is anemic, it is 32 weeks, 31 weeks, I will do transfusion. And no, don't do transfusion. Send we will deliver it out. We will deliver and we will manage postnatally by ex utero this exchange transfusion and all. But that's the worst possible decisions you will take. Okay. So now coming to how do you do the transfusion? We will come to the business area. Now there are 4 components as I have selected here. First, right selection of the case. Right selection of the case, what do I mean? That it is really a baby which is anemic. I am not into the false positive sides. Okay, so my technique, my interpretation should be right. So I have selected a right case, say suppose. Then right selection of the blood, right technique to perform IUT, and right approach for post-IUT follow-up. So not only pre-procedural and procedural, even post-procedural also, you have to have a SOP, how you will follow these cases and when you will call and what is your strategy, everything. So now one by one we will go. First, right selection of the cases. I told you pregnancy with severe fetal anemia from 18 to 35 weeks of window are optimal candidates for IUT, right? Because MCA we cannot do before 18 weeks. It is not validated that MCA I start doing it from 16 weeks, 17 weeks. It has to be done from 18 weeks. So 18 to 35 weeks window. And severity of the fetal anemia, I told you MCA PSV more than or equal to 1.5 multiple of median is indicative of fetal anemia. If you are getting say like 1.3, 1.4, now you have to call that patient after 1 week. You have to have a strict surveillance because they are borderline situation. So you cannot say that I am getting 1.4, it's not anemic, so I am not worried. No, we are worried because normally you will not reach 1.3, 1.4. If you are reaching 1.4 consistently, then this is something, is a point to worry because it may evolve into full-blown anemia and you need to call them back even bi-weekly also, twice weekly to monitor these cases. Okay. Then hematocrit less than 30% or fetal hemoglobin less than 2 standard deviation below the mean value for the gestational age can also be used as a threshold for fetal transfusion IUT. But this you will only come to know when you stick in the needle. Like when I discuss the steps, I will discuss that step. When you put in the needle into the vascular channel, whatever vascular channel we select, and then draw a little bit of blood, and immediately we have a hemoglobin meter, and then we put there and we see what is the hematocrit and what is the hemoglobin, and based on that we take decisions. Okay. So this is not something antenatally you will do. You have to put in a needle and then do. This is an invasive thing. Now right selection of the blood. This is the most important thing. The most important thing. And why I say so? Because first of all you have to get this O negative, type O negative blood cross-matched, packed RBC and
Cross-matched with mother blood.
Mother blood and packed RBC. It should be packed.
Yeah.
Okay, because you don't want volume overload in the fetus, so it should be packed RBC. And the most challenging thing is getting a donor hematocrit in the range of 75 to 85%. That's why, for all practical purposes, we ask them that if they have their own relative, own negative, fresh, that's the best. So get them. Because you have to draw the blood as close to transfusion as possible. Maybe 24 hours, maybe 48 hours, but not more than 72 hours, because hematocrit starts dropping and potassium level starts increasing. So we have to be very conscious with those things, but most of the time they don't have donors. They don't have relatives with O negative, or they are not ready, they are not volunteering themselves, and you have to take from the blood bank. And from the blood bank, most of the time, whatever they say and do, the hematocrit is not 75 to 85%. Because once we take that bag of packed red blood cell from the blood bank and we check it on our hemoglobin meter, it will be like 60, 65, 70%, like that it will be. So those are the challenging situations. But anyway, nevertheless, these are the ideal situation: O negative, cross-matched, packed, and donor hematocrit in the range of this. Donation should be relatively fresh, I told you, less than 7 days, to enhance the level of 2,3-diphosphoglycerate and thus decrease oxyhemoglobin affinity and to avoid hyperkalemia. Because if it is more than 1 week, this level of 2,3-diphosphoglycerate reduces, and then the quality of the blood in terms of the oxygen affinity and potassium level, those all drops, which is not desirable. So as fresh as possible you have to take, and it should be leukocyte depleted. So blood bank does that, leukocyte depletion, they do that. CMV, antibody negative, and irradiation. Now most of the blood bank, they will say we have this blood, okay, we will do leukodepletion, CMV, antibody negative, everything, but we don't have facility of gamma radiations. Now there are two options: either you skip this step and have a risk of graft versus host reaction, or if you have anybody in a cancer center, oncology center, you can send the blood there, they will irradiate if you have a good rapport with them. That is out of way. Because recently we had a case where we had to do, and we had to do tomorrow itself, because baby was having high drops and all, and we arranged for the blood from the blood bank, but they said irradiation they are not having. But my brother is there in Apollo, he's a radiation oncologist, so I could manage that. Out of way I sent to him, and him did that irradiation. But somehow you have to do it, because once in a while you will get that graft versus host reactions.
So why only CMV negative?
This is the commonest one.
Okay.
This is the commonest one, that's why at least you have to rule out that CMV negative. Okay. So this is in a nutshell about the right selection of the blood. Okay. You can take photographs of this. These are very important, because I have gathered it from different sources, and these are the practical things which we are using. Now, right technique to perform IOT. Now, the procedure is performed in a tertiary care center or a fetal medicine unit, and it's a daycare procedure. Now, pre-procedural counseling is very important. How do you counsel the patient? Will you tell this is a magic bullet and I do it and absolutely it will treat it? No. So what are the statistics which you will discuss with the patient during the counseling session? You will discuss that survival rate will increase, and it may be in the range of about 85%, and it decreases with high drops. If it is high drops, like Anisha was saying, if it is high drops, you have to tell them that the survival rate or the chance that this therapy will be successful is 3 out of 4. So 1 out of 4 I may not be successful because of the high drops already set in. Exactly. And if there is no high drops, there is chance up to 90% of successful. So your statistics will be in the range of 75 to 90% depending on is hydropic or non-hydropic. Nothing is 100% in medical science, right? Now, risk of fetal demise also you have to discuss, it is 1 to 3%, because it is possible. You do your best, and then tomorrow when you call for checking, you see there is no cardiac activity. So you have to document this also, fetal demise 1 to 3%. Now, pre-procedural preparation. Pre-procedural preparation, like, okay, we have selected everything. Now we are going to do the procedure. So what all preparations we need to do in our OT? Selection of right patient we have made, that is the most important that we have made. Now, course of antenatal corticosteroids is administered 48 hours before IOT, where emergency procedure is expected. Say like this case of 31 weeks. So a shot of corticosteroid should be given. If it is 22 weeks, 24 weeks, need not. But now it is 31 weeks, so we have to give a shot of corticosteroids for the lung maturity. Then liquid diet 2 hours before the procedure. Avoid any meal 4 to 6 hours prior. Prophylactic antibiotics such as first generation cephalosporin. Maternal sedation if needed. Midazolam or fentanyl may be used to reduce maternal anxiety. Not deep anesthesia, just maternal sedation is sufficient. Because what happens when you try to give little bit deep anesthesia, her excursions are too much. Her abdominal excursions will be not in your control, not in her control. And then you stick in with needle, she will be moving, everything is moving, it becomes difficult. So many centers, they even say no need to do anything, just like how we are doing reduction, just a local anesthesia and do it. Because once she is under sedation or under anesthesia, it becomes difficult to manage her breathing movements. Otherwise we can say, hold karo, 1 minute, illuminating, we can say, otherwise she will not follow. But anyway, that depends on the protocol which you are using. Now choosing the access side. Patient is in front of you, you have cleaned it, draped it, everything is done. Now, where do you want to put your needle in? There are 2-3 options with you. So, one option is you go into the umbilical vein, intra-abdominal portion of the umbilical vein. Like fetal abdomen section, when we take abdomen section, there is a abdominal umbilical vein and portal circulation. So you can choose that because you have to put in vein only, not in artery. So umbilical vein. So you can put there. Okay, this is one. Second is if placenta is anterior, and you have a cord insertion there, where umbilical vein is very well seen and it is in your access area. So that also you can choose because you will come anteriorly and then you have to just target your needle in that vein. And if it is in that alignment, it goes very well. It goes very well. Even if there is spasm, you can manage. Intra-abdominal portion problem happens, it is relatively narrow. If you go perfectly well, it is fine. But if there is little bit deviations here and there or it goes into spasm, then it becomes little difficult. But that decision is only taken when the patient is on the couch, you have cleaned it, draped it, put your probe, and then you have that, okay, which way you want to go. That will be taken, that decision will be taken on the table. So these are the different, and something you should know about the intraperitoneal transfusion. Suppose your intravascular transfusion is difficult, you are not able to do, or you are not well equipped or trained to do intravascular transfusion. Then there is intraperitoneal transfusion. There is ascites in the fetus. You just put in the needle there, and there is a calculation. Based on that calculation, you give your packed red blood cell there, and you expect that will be absorbed by the capillaries into the circulation, and that will cause effect. But this is not the first line. First line is always intravascular. Intraperitoneal is kind of face-saving. If you don't have any option, then you can do that intraperitoneal and come out. Okay. So these are the things. Now, calculation of blood volume. This is the most chaotic area because the moment you put in a needle in the vascular channel and draw blood, then the chaos starts. How much you have to push. You have drawn little bit of blood, you have checked the hematocrit. You have having a hemoglobin meter, you have put there and you have checked the hematocrit. Okay. Some of the meters they will have hematocrit reading, some they will have hemoglobin reading. So 3 into hemoglobin is equal to hematocrit. So that calculation you will do. Now you got an X value. Now based on the X value, how much packed red blood cell you have to transfuse. That decision you have to take. So that decision will be taken on. So you have to assign a person. Like I say, Ankur, your duty will be only in calculation of this. Okay? So as soon as you get, Ankur will start calculating this. So how does the calculation happens? There are 2-3 ways. One is you should know the formula. Okay, but then there are ready-made calculators. Fetal Medicine Foundation side there is calculator, perinatology calculator. Barcelona also have the calculators. So you use that perinatology.com calculator. You'll open. He will keep everything open, and then they will ask what is the hematocrit of this fetus. He will enter there, and then based on the data which there is I will show you that table. Whatever inputs you will give, they will give you the final calculation. But how do they reach to the final volume calculation, that we have to know. And that is volume of the fetoplacental unit. Now what is the volume of the fetoplacental unit? It is 1.046 plus effective fetal weight into 0.14. So whatever is your effective fetal weight today in grams multiplied by 0.14 and add this value, you will get your fetoplacental volume. Because see, I always believe we should be in a zone of AI, artificial intelligence, but we should know the basis of everything. If the system crashes or in the OT you are not getting a network, that also has happened. And calculator, everything is open and then network nahi aa raha hai. Then what? We should have that manual thing also. So this multiplied by final. Now what is final? Final hematocrit, by what hematocrit in the fetus you want to close the procedure. You have got, suppose, a hematocrit, when you have checked, you have got hematocrit of 10 in the fetus. Now, how, at what point you want to stop the procedure? That is your closing hematocrit. So your closing hematocrit is around 45 to 50%. This is fixed. Somebody take, some people they take 55% also, not desirable. 45 to 50% is good enough. So you know your closing hematocrit should be 45 to 50%. So you enter this value, and this minus initial hematocrit. So my initial hematocrit was say like 10. So you enter here, divided by hematocrit of the transfused blood. Now don't believe the blood bank sheet which they give. They will give a sheet also with all the blood details, and hematocrit will be mentioned there. But just blindly don't enter that hematocrit. You from that packed red blood cell, that pack, you draw blood, you check it, and then you enter the denominator. Okay, because for us also they said it is 75% like that, 75 or 85% they said, and it came at 67%. So your entire calculation will change. So do this. So you got it? Volume of fetoplacental unit multiplied by final hematocrit, which is fixed, we know, minus initial we have checked at the entry point, divided by the hematocrit of the transfused blood. That also should be checked. Okay. So this will give you a volume which you have to transfuse. Now I will tell you how to do the transfusion.
Sir,
but before
when you calculating EFW, if the baby has high drops, fetus has high drops.
That is the problem. If the fetus has high drops,
Or
it will
your
always,
facilities,
it will always overestimate it, and we don't have any options, because the time when we take abdominal circumference, the static fluid will be there inside. So just a rough calculation we have to go give and push. We cannot be very accurate. We cannot be very accurate. The case which we did, I was not able to get the abdominal circumference also. It was so distorted with ascites. Somehow just for the calculation sake, we are done. So that will not be very accurate. Okay, but we have to take it that way. Now, this is the checklist for your trolley preparation. Gloves, probe cover, drape set, 22 gauge spinal needle, 20 gauge that chiba needle, that long 15 centimeter chiba needle, one blood transfusion set, 10 ml syringe, 1 ml syringe, then 3-way stopcock, paralytic agent if you wish to, but most of the people we are not giving paralytic agent, because if you give paralytic agent to the fetus and it goes in unfavorable position, it is difficult to do. Suppose baby is facing up and I give paralytic agent and it turns down, then my access is gone. So better not to give it, go ahead and kidney treat, all these things. Now technique, we know that, okay, you will do that, all the sterilization, the dressing, draping, everything. Tocoprophylaxis is important. Now tocoprophylaxis means we want to stop the contractions. Nifedipine 20 milligram 1 hour before, followed by 8-hourly dosing, plus micronized progesterone 200 milligram vaginally morning of the procedure. Or some centers they are using the NTG, nitroglycerin patch, 5 milligram 2 hours before can be given. So if you have this patch, you can use this patch also, but it's difficult to get this patch always. So this is what we use in our center is nifedipine 20 milligram 1 hour before, and then 8-hourly dosing, and vagistrone or whatever, vaginal progesterone 200 milligram on the morning of the procedure. So this is the tocolytic agent. Then small dose of muscle relaxant if you want to give. Okay, so if you want to give pancuronium or vecuronium, we always have that with us, whether we want to give it or not, but it is there in the OT. Suppose I wish to give because baby is very active and all those things I wish to give, so I will be able to. So we have this in the OT, where pancuronium, vecuronium, this is the 0.1 milligram per kg, and intracurium if you have, then 0.4 milligram per kg. Now transfusion line, this is the game changer. Transfusion line, how you are setting up. So you have your, I'll just show you. Okay, let me first discuss this, then I will show you. The transfusion line, usually you will set by the blood transfusion set and 3-way stopcock. So what we do is, there is a that packed red blood cell, that pack, that we will put it, and then through that we will put a BT tube, blood transfusion, and then through that tube we will connect a distal part of the tube, the 3-way, and one part of the 3-way we will attach a syringe, and the other part of the 3-way we will attach a needle. Okay. Now what we do is, before starting the procedure, you have to make changes of the 3-way, so that when you want to draw from that bag, blood bag, it will come in that syringe, and then you have to close it and then push, then along the needle it will go into the vascular channel. So this maneuver you have to do. Okay. And first, before starting the procedure, you will check once all these connections, and then once your needle is inside the vascular channel, first you will draw for checking the grid, and then you will connect all this, and every time you draw 10 ml from the bag by changing the 3-way, somebody has to write, like I ask him, you do this writing. So he will write time, like suppose I have started 3:30, so 3:30, number 1, 10 ml, tick. Okay, so 10 ml, when I am drawing 10 ml, from the bag you see there will be drop in the packed red blood cell, right? I'm drawing, and then I'll change 3-way, and then I will push that slowly, and pushing is, it requires a little strength because packed red blood cell is very viscous. So you push it into the vascular channel, and then again you will change 3-way, and then again draw 10, and then again you push it, and then he will keep writing. Okay, 3:30, now 3:35, second, 3:38, third. He will keep writing. Okay, because if he does not write, many times you forget how many I have taken. And why I am telling you changing 3-way is critical, because it may happen that you will draw the blood from the fetus and you push it in the bag. This all happens, believe me. So you have to be very conscious by checking it, and when you are drawing blood, keep eye on that bag, because when you draw there will be drop there, and then change it and then push. So this maneuver you have to do it, and this maneuver has to be done in a very smooth, non-jerky manner. If somebody just tuck, then it will come out of the vascular channel. That also has happened with me. So we have to be very particular about that. And insertion has to be done by that 20 gauge Chiba needle. I have discussed with you, small amount of blood is drawn with 1 ml syringe to check the hemoglobin or hematocrit. Now volume of the blood transfused is calculated and required amount is transfused to the fetus. We have seen how it is calculated. So perinatology.com you can use it, but you should know how it is calculated. After confirming anemia, second operator infuses the packed red blood cells using 10 ml or 20 ml, whatever, via three-way stopcock, and fetal heart rate monitoring has to be done throughout the procedure. And once transfusion is complete, now, how do we say transfusion is completed? We have calculated the blood volume, so that much amount of blood we have pushed in the fetus. Now, to say that we have reached the end point, what did I say? Okay, my fetal hematocrit, closing hematocrit should be 45 to 50%. Now, has it reached 45 to 50%? How do I know? I have to draw and again check it. But the catch is, like, you have done your last push, last 10 ml or 20 ml of push you have done, and then you take little bit of blood to check. That blood will be that from that packed red blood cell only. So that will give an erroneous. I don't know how sir does. I have to see. What I do is, okay, after my last push, I then push little bit of normal saline. Okay, 10 ml of normal saline after my last push, so that everything is washed out. And then just wait for 1 minute. Just wait for 1 minute, so that everything is pushed and moves into the circulation. And then draw just 1 ml or 2 ml of blood. And then again that same hemoglobin meter, just check it. What is the closing hematocrit? If I reach that closing hematocrit, I will stop. But as Anish was also saying, in high drops, sometimes the calculations may go this way, that way. And I was expecting to close at 45 or 50, but it has not reached. It may happen because of 2-3 reasons. One, your calculation was not correct, it is wrong. Secondly, in between when you are pushing and somebody is changing, that it has slipped out of the vascular channel and it has spilled outside, and you are not getting the desired hematocrit. So in that case, again you give some more top up to be sure that okay, it has reached that level, right? And once you get close to your closing hematocrit, then you can draw the needle out and you can check the MCA PSV. Immediately don't check the MCA PSV. Just you have completed, you pull out a needle and then immediately don't check immediately. Give some time and then check the MCA PSV. So that starts showing changes. Then you have to follow it up. And post-procedural follow-up, how do you do? Immediate follow-up. Ultrasound is scheduled following day. Most cases fetal loss occurs within first 24 hours post-procedure. Immediate blood grouping post-transfusion may be erroneous because it may give negative. Now what happens? There was a case, I remember, when there were a lot of transfusion and then they said, okay, let us decide and then let us just check the blood group of the baby. And blood group of the baby came out to be negative. But people think, okay, it was negative blood group, why did we do transfusion for this? But that negative is because of the transfusion. So please don't check the blood group. just give it. Huh? And subsequent transfusion, now one transfusion you have done. Now what is the schedule like next? When should you plan your next transfusion? That is very important. It's not like one lifetime transfusion.
It's gradually decreasing.
It starts decreasing. So generally 1% fall of hematocrit per day or fall of hemoglobin by 0.4 gram per deciliter after first transfusion. So 0.4 milligram after first transfusion into 3 is 1.2. So approximately 1.2 means round off me 1% fall of hematocrit per day after first transfusion. But after second and third transfusion, it is more rapid, 0.3 and 0.2 gram per deciliter after second and third. Slow. So say like for simplicity, first transfusion only you take 0.4 gram per deciliter, and in terms of hematocrit 1%. So 1% fall. Now you have to calculate accordingly, like you have say closing hematocrit is 50%. So 1% per day it starts dropping, and then at what point of time you want to do the top-up transfusion. Yes. So accordingly you have to plan that. MCA PSV is not used for predicting anemia for timing of second and third transfusion, because once a transfusion has been done, then subsequently you cannot use MCA PSV very effectively, because now your fetal blood cells are mixed with the adult RBCs and they have a different rheological properties. So your PSV, cutoff PSV mom will be different. So you don't rely on your MCA PSV after first transfusion. Rather, you will rely on your 1% rule of drop of hematocrit per day, and based on that, you will decide next when to give up the top up hematocrit, the top up transfusion. Right? Delivery timing, best to plan last IUT at 34 or 35 weeks and plan delivery 3 weeks after last IUT, preferably 37 to 38 weeks. Okay. So this and the complications will be all this.
So one thing, after 3 weeks you said plan for delivery. If need of second transfusion is around fall of 1 hematocrit per day,
Yeah.
then around 15 fall in 2 weeks.
Yeah.
So at that time baby may need second transfusion.
That's why I'm saying ki on a case-to-case basis you have to decide what is your final hematocrit, and 1% rule you know it will drop. Then based on that you decide as close to delivery you do your last top-up transfusion. As close to delivery. You will not wait for 2-3 weeks like that, as close to delivery. But this is much better than delivering an anemic baby and trying to manage it postnatally by exchange transfusion. Right? Now these are the complications, procedural complications: prong, infection, emergency cesarean section, fetal death, all those things. Okay. Then there is separate thing on management of the neonate. So all these cases of transfusion needs to be managed post delivery also. Your duty is not finished by just antenatal management. Okay. Overall perinatal mortality in severe anemia will drop 10 to 15%, and primary goal should be to treat hyperbilirubinemia. Hyperbilirubinemia because they induce because of this bilirubin induced neurological damage or BID, and they cause kernicterus. So you want to prevent this kernicterus rather than anemia. So postnatally, you want to manage this case by exchange transfusion to reduce the load of the bilirubin, because when there is hemolysis, there will be more and more production of the bilirubin. It will cross the blood-brain barrier and start damaging the yeah, it will start damaging the basal ganglia. It affects most, and then it will cause BID. Okay. Now that is a more dangerous situation. So you want to prevent this neurological damage because of this kernicterus rather than anemia. So your goal will be to control this kernicterus. Anemia, obviously you have to do that, but that will be secondary intention. Primary intention will be to check the bilirubin and focus more on intense phototherapy rather than exchange transfusion, because you want to bring the bilirubin level down. Okay, so this is the thing. Like
one more question, sir. Practically, is it given after 18 weeks or after practically 26 weeks?
This
IUT.
See, practically it is better like after 26 weeks, but suppose there is a history, like previous pregnancy also she had developed, then the rule is whatever time gestational age in the previous, suppose previous pregnancy she has developed anemia at 26 weeks or 28 weeks, she has started, then 10 weeks before in subsequent pregnancy she will start developing that. So you have to intervene early in second pregnancy. If it is a recurrence, first pregnancy affected, now second pregnancy and second pregnancy again, 10 weeks before you have to start. But the problem is if you go like 16 weeks, 18 weeks, the vascular access will be, it will be little challenging, because it will be, yeah.
So 1% fall of hematocrit বলছো যেটা 1% fall of তাহলে কি আমাদের daily check করতে হবে?
Not required. Not required. Never. You will not check daily. It's just a rule. Now, whatever is your closing hematocrit, based on that you calculate what will be the top up. At what point of time you want to do the top up. Because
it's risky na daily you should take this.
See, the hematocrit less than 30% for the gestational age is threshold for blood transfusion. So this 30%, now you have suppose reached 50%, and you know that less than 30% baby will be qualified for anemia and I have to treat. So based on that, you have to 1%. You have to see keep where you are reaching, at what point of time you want to repeat this procedure.
So suppose after the post-transfusion is 50, and then if it's a fall of 1% daily,
1%, so 20 days.
so suppose to have 20
So,
days.
so 20 days, okay. Now 20 days it will
So
drop to 20%.
Yes, sir.
20%. So it will 50, it will drop to 30%.
30%.
But exactly 30% will not intervene, okay. So we will wait for at least to become like 15, 20.
So how will you know, sir? Then you have to do a...
No, same calculation. Like you have from 50, it has gone to 30 in 20 days.
Yes.
So in 30 days, there will be drop of 30%. 30%. So 1 month. Okay. So generally, between two transfusions, they give a gap of 3 to 4 weeks. 3 to 4 weeks. So 3 weeks में around 21% drop करेगा, right? And 4 weeks में it will drop to 28%. So 3 to 4 weeks gap generally they put. So
No, I'm asking this as in the first case we have to do an MCI PCV and we understand there is
Yes.
no
Guidance for the second
no,
transfusion.
there is no what I say, invasive procedure. But here, if I have to see the hematocrit, then I have to do an invasive procedure.
Then you have to do an invasive procedure, but we don't do it because we believe कि 1% drop होगा, and then based on
As-
that, एक rough
We
calculation.
take it as a whole. Okay.
We take it, हाँ.
Okay.
That is the thing.
That's the thing I was asking because
हाँ.
another invasive procedure that will be in the
हाँ, no.
Okay.
We don't do that. We don't do that. And MCA PSV may be misguiding.
Yes.
So a rough calculation
Just
happens.
take it a rough calculation.
Rough calculation
Yes,
of
okay.
1%.
Okay, I understand.
And then based on that. So when you plan, that's why I'm saying that exactly borderline 30% they will not intervene. You always say, okay, it's 15-20%. Then again the top of dose will be
Sir,
given.
is there any nomogram between the MCA-PSV and the expected hemoglobin level of the fetus?
Yes, there is. I will give you. Yes, I will give you. There's nomogram for everything. But just some thumb rules we should know how to calculate this so that it will help us on practically. Otherwise there are all these formulas are there. So we'll stop here.